via webinar as well. First off, I would like to begin by acknowledging that the land on which we gather is the traditional unceded territory of the Physiological Okanagan Nation and their peoples. And my name is Brian Dalton. I'm an assistant professor here at the University of British Columbia, Okanagan, and I'm with the School of Health and Exercise Sciences. And I want to say that today's webinar is in partnership with Embrace Aging and our Institute for Healthy Living and Chronic Disease Prevention. It's also hosted by the Institute for Healthy Living and Chronic Disease Prevention, as well as Interior Savings Credit Union and Interior Health. For those who have questions for our speaker, Jennifer Davis, we would ask you to raise your hand in the room, or if you're on the webinar, please type it in your chat box. Without further ado then, I will introduce Dr. Davis. She's an assistant professor with the Faculty of Management here at UBC Okanagan. And today she will talk about preventing falls among seniors and how much do better health outcomes cost. So I'm going to pass it over to Dr. Davis.
Great, thanks so much, Brian. Okay. Hi, everyone. So today, really, what I'd like to start out with is my why. So why do I care about preventing falls? I'd like to share with you a quote. And this is from an 82-year-old woman who I met during my master's training, who sustained a hip fracture after a fall. She said, "The minute I hit that floor, my life changed. It has been downhill ever since." Now this is a woman who fell walking along the street, fractured her hip, and then never returned home. And this is one person's story, but it's a common story among people who have fallen. The good news, though, is that falls are preventable. The consequences of falls are substantial, but we can prevent them, and we can do so efficiently. So today, what my goals are is to basically discuss with you and be able to recognize that falls are a costly problem and examine, first of all, how do we assess fall risk, and then how do we prevent falls. Among the strategies that we know effectively prevent falls, then looking at what strategies are efficient. So which of these strategies provide good value for money? And then from that, how can we optimize efficiency? So examining the role of adherence in improving intervention efficiency. So we know that falls represent a significant problem, both in terms of fall-related disability, fall-related injury, as well as fall-related mortality. In Canada alone, we spend over $2 billion annually on falls. There's also a lot of new healthcare technologies, interventions that are constantly being put forward to prevent falls. However, usually these come with an increase in cost. And so this is why it's important to really evaluate the efficiency. So what is the value for money of different prevention strategies? Now, a couple of systematic reviews have demonstrated that in terms of societal costs of spending over $9 billion annually, there are a large variation in terms of techniques examined to estimate costs. There's a lot of heterogeneity in costing approaches, but the bottom line is falls are expensive, and we can save our healthcare system a lot of money by preventing them efficiently. So to start with, how do we screen for fall risk? Well, the simplest level is just asking your patient, have you fallen in the past 12 months? So generally the simple question is a good indicator for the next fall. It's not so good in terms of having information about preventing the first fall. Often the first fall can be a trigger for a downward cascade of health outcome events. There's also a number of mobility performance tests. One factor that is important that can't be ignored is cognition. So there's really quite a well-demonstrated interplay between cognition and falls. Now, just looking at cognition alone, we know that one new case of dementia is detected every 4 seconds. We know that falls are a problem, resulting in reduced quality of life as well as functional decline. Now, there's an important relationship in that traditionally we often think of physical function, so poor balance is an indicator of fall risk. But not so often, we're not always thinking of cognition as being an important factor of fall risk. We know that even mild decline, so people with mild cognitive impairment, are at least double the risk of falling. So assessing cognitive function, particularly looking at mild cognitive impairment as a good point for intervention, is also important in terms of falls prevention. Another test is the timed up and go. Quick show of hands, how many are familiar with this one? Most of you in the room, so I don't need to describe it for you. The basic threshold for the timed up and go is that community dwelling people should be able to complete this in approximately 14 seconds or less. There's also the short performance physical battery show of hands. Probably most of you are familiar with this one. Yeah. Again, this consists of timed standing balance, repeated chair stands, and walk. So each item is scored out of 12, and that's also another good marker of mobility impairment.
You want me to get
The sit-stand test is one used a lot by our colleagues at Harvard. It's, again, a quick marker that can be used clinically, looking at patients' ability to sit to stand independently with their arms folded across their chest. Now, Stephen Lord and his group in Australia have developed a number of useful screening tools to assess for fall risk. The most recent one that they've developed is called the Quick Screen. Now, the Quick Screen is basically a test that can be done in about 15 minutes that asks for patients' information on previous falls, medication, vision, their peripheral sensation, as well as looking at strength, reaction time, and balance. And what it comes up with is a report, an individualized report for each patient detailing which factors they are weakest in, and thus providing basically suggestions for where intervention should take place. Developed by the same group, Professor Stephen Lord developed the Physiological Profile Assessment. Now, this is a much more comprehensive assessment that takes at least 30 minutes to perform. And basically what participants receive at the end of this test is a report on their fall risk. So on the graph here, you can see that the red region means that they are at marked risk for falling. So what this highlights is that the blue zone is normal. So for participants that are in the red zone, that really is detailing a high-risk group that would greatly benefit from intervention. Along with seeing where they're at relative to their peers, is that patients will receive an individualized assessment of each risk factor that they have for falling. And so this is useful in terms of tracking their fall risk over time. As well, sometimes patients generally find it helpful to know where they lie in comparison with a normal population. Often this can be motivating in terms of if they're doing exercise interventions, or it can also be useful in terms of they can see how well they've done after an intervention by seeing where they've moved to on this fall risk graph. So how do we prevent falls? There's really extensive base of literature on fall prevention strategy, and there are several effective types of strategies. So we know that multifactorial interventions work. So there's been several seminal studies by Jacqueline Close, Mary Canetti, that detail multifactorial approach to falling. So this might include geriatrician visits, nutrition review, medication changes, as well as several different behavioral intervention strategies. Multiple approaches may also be effective. So one example is a stay on your feet intervention that was done in the United States. Again, a community-based intervention where participants receive support from other individuals in the program. So some multiple interventions, such as stay on your feet, have also demonstrated effectiveness. There are also a number of single-factor interventions. I'm going to focus predominantly on exercise. We'll talk a bit more about why later. But single-factor interventions just focus on one risk factor. So they're targeting one individualized risk factor for falling. So resistance training is often a common single-factor intervention that has demonstrated efficacy for preventing falls. And it's really a key component of most falls prevention strategies, often combined with balance training. There are also economic benefits to be had through falls prevention. The average cost of injury fall is about $30,000 per person annually. Now, you may ask why behavioral interventions. Really, behavioral interventions have multidimensional benefits. So we might be targeting or using a single factor intervention, but the benefits from that single factor intervention are multiple, often improving quality of life, cardiovascular benefits, cognitive benefits, as well as mobility benefits. Now, Wiseman and Donaldson put it nicely in saying that essentially for priorities to be set, the key question is not which health problem results in greater burden, but rather which intervention aimed to treat this health problem is a best buy. So here, considering the concept that it's good to know the cost, it's good to know falls are costly, that helps establish it as a burden and priority in terms of policy decisions, but it's also very useful to know which interventions are most efficient, where is our best value for money. So again, it's not just about cost, it's about health outcomes as well. So a fundamental fact of life is that resources are scarce and decisions need to be made. And the cost of healthcare is high and it's always rising. Now, a major contributing factor is the introduction of new healthcare technologies, which generally come at a greater cost. So you pay more for better health outcomes. In reality, this is difficult because it involves the need to disinvest from other programs. So cost effectiveness analysis, or CEA detailed here, is basically a tool that we can use to guide priority setting. So what is economic evaluation? Well, really, it's looking at the same time, so looking simultaneously at the costs as well as at the benefits of particular interventions. So one systematic review published in the British Journal of Sports Medicine reviewed all published randomized controlled trials of falls prevention strategies that included an economic evaluation. And what we found from this study was that the greatest value for money, in fact, interventions actually saved healthcare dollars when they were targeted at high-risk groups. So, for example, a multifactorial program that was targeted among people who had at least 8 risk factors for falling was cost-saving. If targeted at 4 or more risk factors for falling, was cost-effective. So this is where it would depend on how much decision makers are willing to pay. Another program, the Otago Exercise Program, would also save money if delivered to people who are 80 years and older. So again, this high-risk group. Interestingly, in response to this study, the evidence for the Otago Exercise Program was tabled at New Zealand Parliament. So now in New Zealand, they offer the Otago Exercise Program available just to community members who are 80 years and older, which is fantastic. There's also a home safety program, so looking at home hazards, home modifications, was cost-saving, again, if participants had had a previous fall. So take-home point here is that you get your best value for money in terms of targeting your groups most at risk. The pictures you see here are actually pioneers of falls prevention, so John Campbell and Claire Robertson, who published some of the original work on the Otago Exercise Program in the British Medical Journal. So I'll just share with you a snapshot of an economic evaluation I did, and it was basically looking at the value for money of 2 different doses of resistance training in older women. So just briefly, these women were 60 years and older, relatively high functioning, they were community dwelling, and they participated in a 12-month randomized control trial. And so there was a total of 120 women, and they completed a 12-month exercise intervention. So they exercised either once weekly or twice weekly. Now the results of economic evaluations can be plotted on what we call a cost effectiveness plane. So on the y-axis, we have cost. You can see at the upper portion, in the north region, we have new treatments are more costly. This is generally where we see new treatments lying. On the lower south portion, we have new treatments that are less costly. And then on your x-axis, we have your measure of effectiveness. So the results of this study, first I'll just go over. So for example, if you have a new treatment that's more costly and less effective, we'd say that the existing treatment is better. So often health economists refer to that as a no-brainer. We're not going to pay more for worse outcomes. More commonly though, what we'll see is we'll have a new treatment that's more effective, but you have to pay more for it. So you have to pay more for better health outcomes. And this is where you depend on a decision maker's willingness to pay for those better outcomes. You also may have a new treatment that's less costly and less effective. This is another one that generally we would decide not to go for. In the case of this trial, what we found was that 100% of the results were within the southeast quadrant. So the new treatment was more effective and less costly for both once weekly and for twice weekly resistance training, meaning that both doses of the resistance training provided better value for money. Now this was a perspective that incorporated all healthcare resource utilization related costs. So it was a healthcare system perspective. So in conclusion, an individually tailored resistance training delivered twice weekly or once weekly dominated a balance and tone alternative. Of note, the twice weekly resistance training group did also demonstrate clinically significant improvement in their health-related quality of life compared to both the once weekly and the balance and tone group. Now, moving on, that's one example of looking at value for money strategy such as resistance training to prevent falls. Now, in general, the biggest struggle with behavioral interventions, as many of you in the room know well, is adherence. So looking at, we know that these interventions can work in an ideal situation where things are tightly controlled in a randomized controlled trial. But how well do they work in the real world? And perhaps our greatest gains can come from understanding what areas affect individuals' adherence and how can we improve that. So I'd just like to share with you most recent study that we just published in the British Medical Journal Open one of a geriatrician-led evidence-based multidisciplinary program we have going both in Vancouver as well as we have another site in Prince George. So this is a multifactorial approach to falls prevention led by a geriatrician, but it involves a multifactorial approach to preventing falls. So this was a 12-month feasibility and acceptability cohort study among older adults attending the falls prevention clinic. So we know that falls lead to chronic disability and injury and death worldwide. We also know that a multifactorial approach can prevent falls up to 40%. So if you consider that each fall may cost approximately $30,000, preventing 40% of that, you can have huge, huge, huge savings. But there's a gap. So there's a gap between knowing what works and what can work in the real world. So the goal of this was to look at factors contributing to the feasibility and acceptability of this multifactorial approach that's currently happening in a real world clinic setting. So our goals were to assess the feasibility and acceptability of this geriatrician-led multidisciplinary falls prevention clinic among older adults. Again, they were high-risk older adults. So everyone at the falls prevention clinic has had at least one fall in the past 12 months. So we assessed feasibility by measuring demand and acceptability by measuring overall and domain-specific compliance, as well as looking at their monthly fall calendars and qualitatively at patient experience. So just to give you an overview, what is the falls prevention clinic? Well, the key goal is to identify underlying risk factors contributing to our patients' falls. So looking at patients' individualized fall risk factors. Secondly, to address these risk factors to prevent future falls while working in consort with a team of healthcare professionals, so working with geriatricians, working with physiotherapists, nutritionists, etc. So what happens at the falls clinic? Well, step one is your initial appointment, which is, again, all patients are screened to ensure that they are high risk. Patients come in, they receive a battery of assessments. So they receive a battery of comprehensive cognitive assessments to basically identify any cognitive deficits and how that might relate to their fall risk, as well as a battery of physical assessments, some which I described at the beginning of this talk, and thirdly, a geriatric exam. Now, the geriatric exam, patients will have their medications reviewed. They'll have home hazards assessed. They'll also have habits such as alcohol, smoking, different things like that ascertained, and then they will be given a series of recommendations. So from the risk factors identified, referrals will be made. So these might include physio, occupational therapy, other specialists. There'll also be recommendations for factors that are modifiable. So what we're looking for is to provide recommendations for factors that we can change, such as environmental hazards, medication changes. So one example is that a lot of patients who fall take sleeping medications. So often these are cut back in dose, or they are suggested that they remove them. Other things are glasses, so progressional lenses, as well as footwear. And last but not least, different tests or investigations are often ordered. So what we do is we follow up these participants over 12 months, again at the specification of the geriatrician, and then we assess their falls risk at their follow-up to compare how they've done and what their trajectory looks like. So it's really a feedback loop. We start with our referring physician. There's an initial appointment, there's recommendations, there's follow-up, and there's feedback at each of these stages. Just to summarize the study design, it was a 12-month prospective cohort of 188 women and men who were at least 70 years of age. So we assessed feasibility and compliance. For compliance, looking at specifically if they were compliant to the following recommendations. So referrals, tests, medication changes, and then the last two, behavioral exercise and lifestyle modification. So just to give you a snapshot, this is small, don't worry about reading everything, but we're looking at an average age of 81. I talked about the tug at the beginning with a cut point of 14 seconds. You can see that their average here is 17. So again, highlighting that this is a more frail, high-risk group that we are dealing with. Also looking at their MOCA scores, the Montreal Cognitive Assessment. It's a score that's often, an instrument often used for mild cognitive impairment, so a cut point of 26 is used. You can see that these individuals...
Carry on.
Okay. You can see that individuals really are at high risk, both from the cognitive aspect as well as from mobility markers. So this table here details their compliance to recommendations. So what we see is that their compliance is quite high to adhering to going to follow-ups, test or investigations, medication changes. Little bit lower for exercise, so 58%, and lifestyle, 35%. Again, these are behavioral ones that it's lower to, and often these are harder to make change. Now we asked participants, so we conducted a number of directed interviews and asked participants what factors influence their experience. And from this, we reviewed their responses and identified several themes that impacted patients' perceived physical benefit. So one was improvement in their fall-related self-efficacy. So improvement as well in their falls risk and accountability in maintaining compliance to exercises. So they found that the clinic helped them maintain accountability. And there was also physical benefits of having exercises directed by a trained physical therapist. I'd like to draw your attention to one quote that a participant said. The follow-up by the clinic helped me stay on track to make sure I was doing the exercise properly. My balance has improved beyond expectations. I cut my balance risk by half. I should say a big improvement. I appreciate the Falls Clinic more than I can say. This is just one example, but again, emphasizing that point about the clinic helping with overall accountability. Now, patients were also asked about factors influencing their satisfaction with the clinic experience. And so they really, the predominant themes that came up were that it was an integrated approach. So several patients commented on liking the aspect of feeling like their whole self was being taken care of within one centralized clinic. Also to do with program reliability, so feeling like it was a clinic that they could depend on. Just draw your attention to one quote here. Prior to coming to the Falls Clinic, I was in very bad shape. I was constantly scared of falling and injuring myself, which prevented me from doing many of my usual activities. The advice, suggestions, and change in medication has overall brought big improvements. And this is a story we hear quite commonly. People not leaving the house because they're afraid of falling, especially here in the Okanagan in the winter, afraid of the ice. And so really this impacts their quality of life, their enjoyment of life, which is important. We want to optimize people's quality of life. So in summary, we found the overall compliance to clinic recommendations was fairly high, almost 70%. However, the least compliance was noted for basically recommendations involving behavioral change. So exercise, lifestyle modifications. Examples of lifestyle modifications might be recommending reduction in alcohol intake is one that often is hard for individuals to change. That's just one example. Now, factors that provided evidence for feasibility and acceptability is that patients received several levels of physical benefit. So they felt that they benefited from physiotherapist-directed exercise. They noted improvements in their fall risk based on the report I showed you at the beginning, the physiological profile assessment. They also appreciated being basically prompted to be accountable, and they had less fear, so there are improvements in their self-efficacy. So basically, what this study does is it provides some triggers. It provides some ideas for next steps forward in terms of looking at factors that we could potentially target in future interventions of fall prevention strategies that would allow us to improve adherence. Right now, across the falls literature, we're looking at about a 30% adherence rate to most exercise interventions. So even if we could bump that up by 10%, we would save a huge amount of healthcare system dollars that could be attributed elsewhere. So that's the idea. That's the reason why this study was taken. So take-home messages from today. Falls are costly. We can prevent them. Our greatest value for money comes from targeting individuals who are most at risk. So looking at people who have fallen before, people who have poor balance, people who may have mild cognitive impairment. We're still working, so further refinements are needed to promote adherence, and ideally by promoting adherence, we may see the greatest gains in our efficiency. So I'd just like to thank, the pictures at the top are of our very dedicated geriatricians at the Falls Prevention Clinic, and some of them fly to Prince George to serve at the clinic in Prince George monthly. So none of this would be possible without them, as well as our dedicated patients. And thanks all of you for the opportunity to speak today. Thank you.
Thank you, Jennifer. So there is time for questions. Reminder to those on webinar, please fill in your chat box if you have questions. And I'll open the floor for questions for Dr. David.
Mary. Oh, sure, yes.
I'm curious about the SDS and how that factors into cost analysis. The Vancouver trial specifically seems amazing and really expensive to implement or to run, which doesn't impact the cost effectiveness analysis. It's just more like, yeah, who is privileged to go and who's medical advice? Is there evidence that people who are more susceptible to falls are less likely to have any percent? Yeah, what is going on?
Yeah, and that's a great point. You know, within the falls clinic, oh, sorry. The question was, how does socioeconomic status basically impact the efficiency results, or the results of the economic evaluation? Is that a fair summary, right? Yeah. Okay. So in response, it's a great question. So just to clarify, the clinic sees anyone. So some referrals come from eMERGE, where generally you will see lower SES. I didn't report it here, but just looking at education as a marker, we had a fairly widespread individuals with less than grade 9 education, and then a few that, you know, had university degrees, were professors, healthcare professionals, somewhat shaped like a bell curve, as you might expect, where there's less people on the peripheries of those two extremes, but certainly no one is excluded from the clinic. Again, there is the issue of people not having a physician, and the clinic does require a referral from a healthcare professional. So whether that's a physician, a physiotherapist, it needs to be some sort of healthcare professional. The clinic does take referrals across the province. Generally, our referrals are mostly from the Lower Mainland, just due to access issues, but certainly the door is open. But you know, and that's a variable that we certainly control for in the economic evaluations. So I think that's a great point. Yeah.
I have a question from the web room. So for those elderly that fall and are not injured, what % cannot get up?
Right. So those who fall and are not injured. Yeah. So I don't have a specific percentage on that one. So I don't know the % on that.
I have another question. When you mentioned assessing fall risk using a timed walk test, were you referring to the tug test?
Yes. Yes.
Okay. Would other tests that assess gait speed also be used?
Yes. So generally within the clinic we use all of those tests. So we use the timed up and go, the short performance physical battery. We do a number of other, we assess their gait speed, so they do a 6-meter walk. They also, like I mentioned, do chair sit to stand, and so various measures of their function are examined.
Any other questions?
How long would somebody who's referred into the clinic, how long is their appointment? Is it about an hour for the initial appointment?
Repeat the question. How long is their appointment? So the appointment can range between 2 and 3 hours.
Okay. And so throughput in the clinic in a given day, how many patients are they able to see?
Usually a maximum of 6.
6 a day.
Yeah. So usually people go through stations. So the geriatrician will continuously see one new patient every hour, and the geriatric assistant will be doing the cognitive screen and the physical function screen.
So how many staff are there? You have a geriatrician and one tech?
Yes,
and then
correct.
Your MOA?
Yes, correct. Yeah.
Dr. Davis, I was making a note from the beginning. You talked about are you at risk test or point. I sort of just have mentioned that, can I finish my bit?
Oh, sure. So maybe I'll just go back. Is this the one that shows me all the slides, or? I'll just go off. So the question was, how do you screen for falls risk? I'm just going to go back. Beginning. Right. So at the simplest level, asking, have you fallen in the past 12 months? So that's good in terms of marking risk for future falls. However, that one's less helpful in terms of preventing that first fall. After you've had the first fall, then you're already at increased risk. And then there were the other measures. Did you want me to go through those, or?
Yeah, because someone could be at high risk for falling, but not having fallen in the last couple months.
True, yes. And so then that's why we look at cognitive decline.
Cognition.
Yeah, so using the Montreal cognitive assessment is a good marker in terms of the cognition. And then looking at the time up and go, so using a threshold of 14.
And being over 80.
Yeah, being over 80, so age is a big one as well. Yeah, absolutely.
Having poor balance.
For balance, yeah. So that's what the physiological profile assessment has a balance component. So it assesses several aspects of balance as well as peripheral sensation, reaction time, vision. So the physiological profile assessment basically assesses the whole range of physiological reasons why an individual might be falling, which was this one. So the quick screen is actually basically a condensed, it's meant to be utilized in a clinic more efficiently just because it's shorter. So it's taken, they did an analysis and basically took the aspects that they found most strongly predicted fall risk from the physiological profile assessment, and then they developed the quick screen.
Is that available online?
You can look at it. It does come at a cost. So quick screen kits can be ordered, and then all the analytic tools that come with your output can be done online, but it all is patented by Stephen Lord. So there's a cost of purchasing the initial equipment. Yeah.
The reason I asked is that I volunteer with a group at First United Church, and we assist mostly ladies who get right into this. Most of them are well over 80.
Yeah.
Very active, and I think they benefit most from coming out for short walks,
Right.
some exercises, and the social aspect.
Right.
And if we ask them at the end of the 12 weeks, if they're twice a week, most of them will say what they enjoy most about it is the social aspect.
Right. Yeah.
So, are you finding that that's a looking at someone with a risk for falling, if we can get them to enjoy life more, have more purpose, even while comfortable, that their risk for falling
We certainly notice, so comparing, home-based versus group-based exercise, generally we see patients have greater adherence when they are partaking in groups. So certainly that, if it's an effective intervention, certainly that would contribute to better outcomes.
That's a surprising and very nice side effect of taking people out of their closer homes, putting them into assessments, which you are after scientific things, but find that one of their greatest improvements is their enjoyment of life.
Yeah.
Social.
Yeah, which is fantastic. It's,
Which then improves cognition.
Yeah.
Which then improves social issues.
Yeah, yes, absolutely.
Or were you, to phrase that as a question, were you finding any of that? That you the researchers would work with your people for over years.
Yeah, we certainly, we do have some video testimonies from participants who, have reported, improved quality of life, have demonstrated quite a bit of sadness when the intervention ends, missing that group contact, and then some have gone on to continue being friends with people that they were exercising with, and so maintaining the goal. The hope is that some of those benefits, continue to be maintained beyond the intervention. Mm-hmm.
And how were you helping the participants with their fear of falling? Some, like we've even seen that people not even wanting to go up their acceptability or their sitting through the winter for fear of falling. That's a huge first step.
Mm-hmm. Yeah, so
What strategy?
our strategy was to target their risk factors for falling, so that ideally over a 12-month period they will see change and they will notice change, and then in turn that would allow them to be more confident.
So then the people that you got into your study
Mm-hmm.
have already passed that threshold of having a fear for falling.
We didn't
The
screen
fact that
them.
they came out means they're no longer have that huge fear of falling. And I'm wondering if there's a whole group of people out there who never came to your study.
Mhm.
We don't know where they are. They're at huge risk for falling, and they won't reach forward. Nobody even knows they exist because of their fear of falling.
Mm-hmm. Yeah, absolutely. It's
They're so hidden.
not possible to target everyone, but that is definitely a vulnerable group that
How do we find and identify that?
it's a good question. Beyond my area, but definitely important. Perhaps some of our fall colleagues might be able to jump in.
Well, I wonder if you're saying in the Vancouver Fall Friendship, they're being referred by emergency room visits.
Yeah.
Then that really vulnerable group who end up in the hospital would then get referred. And that doesn't mean that. Yeah, and how sad it is, but that's how they get referred. Yeah. Where their fear of falling is when they finally end up. That's the first time anyone discovers them. Is when they do have a fall. How do we reach out and identify them
Mm-hmm.
who are at huge fear of falling?
I think
I
that
talked to ladies that haven't been out in this horrible month of February, haven't been outside.
mm-hmm. Absolutely. Even one of my parents falls in that zone, and I think that's an important group to reach. And I think it also speaks to the importance of the clinic, which is why we are, aiming to have satellite sites across the province, like having a site in Prince George to open up northern BC, so people who are really frail don't have to go all the way to Vancouver to get help. So it's a work in progress, but certainly, if you saw our participants, they are extremely frail, a lot of them, but also really wanting help. So they do seek whatever support they can get to actually get to the clinic. So the ones that we see are wanting the help, and I think that's also reflected in some of the compliance data that we saw. So 69% is pretty high for a frail group, but impressive, right? I think it's a story of success that could motivate others who are really frail as well.
My concern is that it is the group that doesn't show their help.
Yeah.
Because they're sliding into a huge cycle of depression.
Yeah. Yeah.
My wife's mother is in this sort of group, right? And she fights against wearing anything around the hips to protect the hips.
Mm-hmm.
She won't use a cane or a walker because she doesn't want anyone to think that she's getting a little bit of doddery and likely to fall. She just falls. Unfortunately, not too bad so far. But to what extent do hip protectors and walking apparatus prevent falls?
Oh, yes. So to what extent do hip protectors prevent falls? Hip protectors are shown to be effective. So they do prevent fall-related fracture. However, the biggest issue there is, again, like you just mentioned, getting people to wear them. And it's particularly getting people to wear them when they're in situations where they're putting themselves at the highest risk. So it always comes back to adherence.
What about walking sticks?
Yeah, and walking sticks, that you always have that classic picture of the person falling and their stick is in the air. So walking sticks are not generally a recommended strategy to prevent falls. Because of that, it almost gives the person the perception that they can hang on to something, but it's not rooted with anything that will prevent the fall.
And a walker?
Walkers, again, adaptive aids, so if they are prescribed, then it's not considered a hazard like a cane, for example, not to that extent.
Are there any other questions?
So I have family members who are older and they're not really like to go to the gym or necessarily like join a program. If they try to, I mean, they can do minimal things on their own, like they'll walk around, walk, or grocery shopping. If I want to encourage them to get more exercise or try do resistance training at home, like I was wondering if there are any specific things that I could encourage them to do, like would it be, like,
Right, yes, so there, Teresa Luambros and her group, so working with her and Linda Lee, we have a YouTube video that shows how to do the Otago exercise program. So if you would like, I can provide that link. Basically, it provides a video explanation of how to partake in all the home-based exercises of the Otago exercise program, which is a well-proven fall prevention program. Yeah.
sorry, what was the name of the program?
It's called the Otago exercise program. Otago, so O-T-A-G-O, exercise program.
O-T-A.
G-O.
Yeah.
Sure. Yeah.
Anyone else? We've had some excellent discussion. Okay, if there are there any other questions online? Okay, if there are no other questions, I'd like to thank you all for coming and those on the webinar as well, and I'd like to thank Jennifer for speaking for us today.